I did have one question over one of the questions on the exam, if that's
Mhm.
okay.
Yeah.
Um, Talking about the aerosol therapy, the breath enhanced versus the breath actuated. Like, I know the difference between the look of both of them. One
Mhm.
has the valve, one's kind of the closed system. So the breath enhanced has the valve on it. The breath actuated is that kind of closed system. What, when I tried looking it up, but I just couldn't in the book and Google didn't behave either. What is the best like patient or who is going to benefit the most from one versus the other?
That's a great question. So with the breath enhanced, their first thing that clinics and hospitals look at is which one is cheaper. So you're going to pick those for your more chronic patients, your CFers. If you are performing a test, I know National Jewish will use the breath actuated ones when they need deposition of medication for like a methylcholine challenge um, to help with diagnosis with PFTs. So it's going to be based on the needs of the hospital and then cost. Like I know I have some CF mom friends in California and their clinic gives their CF patients breath actuated and Maryland's gets breath enhanced. So breath actuated, the last time I looked, those nebulizers cost about $6, depending on how many you buy, so wholesale or how big your clinic is, $6 to $15 a piece for just one neb. And then the breath enhanced were more like $2 a piece.
Okay, so that's going to be your main difference. They're going to kind of hit the same mark for patient
Yeah,
treatment, but it's going to be based on hospital need.
yep. And
Okay.
then like if you go out to I know from CF clinics and then CF inpatient. So at Children's and St. Joe's, all the CF patients who are inpatient are going to have those perinebs that are breath enhanced, whereas the rest of the patient who's there getting respiratory treatments are going to have the regular little acorn nebulizers because those are even cheaper. Good question. Okay.
Cool. Thank
So
you.
let's start off with a couple questions before we get to our PowerPoint. What are some disease processes that require airway clearance therapy that you can think of or would benefit?
CF
CF,
is a
what
big
other
one.
obstructive diseases?
Bronchiectasis.
Yep, bronchiectasis. What about COPD? So COPD, chronic bronchitis. Neuromuscular diseases, because they're not going to have that strong cough that the typical patient would have. So they are going to need some help getting those secretions out just because they can't take those big, deep breaths and their diaphragm isn't as strong to generate the cough.
Post-op patients.
Post-op patients, yep, we're going to talk about how we will modify their coughing techniques to help them cough and keep their lungs open. What are some negative effects of retained secretions?
Bugs love it.
Bugs love
It's
it. Yep.
nice.
So
Yeah, nice
infection.
breeding environment.
We have a risk of increased airway resistance. So patients can air trap and mucus plugging, which can cause hypoxia and inadequate gas exchange. So we want to prevent all of that. Okay. So guided cough. So teaching an effective cough is imperative for our patients. And there's two key factors that we need to think about. We need to think about proper position. So we want them sitting up straight. If they're in the chair or on the edge of the bed, planting their feet firmly on the floor and having them balanced. If they can't sit up in their bed or on the chair, we need to make sure that we raise the head of the bed up so that we can make the lungs long and straight. And then breathing control. So we want to have effective inspiration so that we are filling the lungs up with air. When we're teaching directed breathing and coughing, we want to guide them and tell them that they need to breathe in through their nose, because remember, we want the gas to be heated and humidified properly. So breathing in through the nose and then exhaling through their mouth. Oh, hold on just a second. I got to fix my screen. Okay. So we're going to talk about directed cough first. We always go by our AARC clinical practice guidelines. We are going to, when we're working with patients who are on the respiratory service, we are going to have them cough pretty much with any breathing treatment. So if we're doing PEP, postural drainage, CPT, if they have retained secretions and they're there for an infection or exacerbation of COPD or asthma, we want to help them get those secretions out. If they have atelectasis, directed cough is going to help them open their lungs and splint open those airways that are collapsed. Post-operatively, we want to make sure that they are not going to develop atelectasis. And with routine bronchial hygiene. So if you're working in an asthma clinic, a CF clinic, you're working in a pulmonary rehab or with COPD patients, we're going to teach them directed cough techniques and breathing techniques that they can do at home to maintain their bronchial hygiene. And then we do directed cough, like I said, with other bronchial hygiene therapy that we are performing. So here are contraindications. These are all relative. So what's the difference between relative and absolute?
For the contraindications?
Yeah. So you have relative contraindications and absolute contraindications.
I mean, absolute is going to mean absolutely do not do directed cough. You're not allowed. And relative is kind of based on the degree of
Yep.
contraindication.
Patient needs. So it's outweighing the risks versus the benefits. So these are all relative contraindications. So infection. So if our patient is there for a respiratory infection, we are more than likely going to do directed cough with them as part of their bronchial hygiene. If they have a respiratory infection like COVID or tuberculosis, we won't do directed cough because we're worried about the aerosol particles for us as well. Okay. And then increased ICP. So if they've had a like a TBI, a traumatic brain injury, or if they've had an aneurysm or a stroke and they have a slightly higher ICP and it's not being monitored, then we could still do directed cough. If you start to notice that it is affecting their mental status, or they start complaining of headaches, or the doctor will write in the notes, patient needs to maintain a low ICP, then that would be a contraindication we would follow. If they have an unstable head, neck, or spine injury, we want to keep them as linear as possible and try not to aggravate that injury. So this is not to be used on patients who are obtunded, paralyzed, or uncooperative. So if they're obtunded, what does obtunded mean to you? What do you think that means?
Lethargic, non-responsive.
Yep, not responsive. They can't follow commands. So their mental status isn't where it needs to be to perform directed cough effectively. If they're paralyzed, we're probably, if they're paralyzed with medication, they're going to be on a ventilator. So we're going to take over their secretions for them. So we're not going to be able to make them cough. If they are physically paralyzed from an accident, then we are going to learn in this lecture, we're going to learn other ways that we can help them cough to move their secretions. If they're uncooperative, so they're mentally capable of doing this and they're just refusing to do it, obviously you're not going to be able to do directed cough with them. Teaching is absolutely critical. It's imperative that we teach them the proper steps and demonstrate how to do it, as well as why it's important, because patients are more likely to follow through with what you teach them if they understand the why. I mentioned earlier, be mindful of positioning. So sitting straight up, having their lungs nice and long so that they can open their lungs as much as they can. And then we can modify the technique based on the patient's condition. So based on the disease, the patient's education level. If they're post-operative, we can splint, and we'll go over splinting. If they have a neuromuscular disease, we can modify it so it best fits the patient. So it's good to practice to encourage the patient to cough after bronchodilators, because now their airways are not spasming, they're open, they can get that mucus out after CPT and then other airway clearance therapy. So after they do a chest wall oscillation, so a vest, a PEP, easy PAP, any of those things. And then if we need to get a sputum sample, teaching them how to do a proper directed cough will help us get that sample we need. So the standard directed cough, we are going to be in the sitting position. And then on the inspiration phase, you want to inhale slowly and deeply through the nose. And then you're going to have, I'm going to grab my tissues so I can show you. So in through the nose and then bear down on the glottis. And then you want to demonstrate it for your patient. So you'll say, take a big breath in and then add pressure to the throat area. So a big part of being an RT is wording your instructions so your patient can understand. Majority of your patients aren't going to be like, what is a glottis? So you're going to tell them to bear down and make themselves cough. So, and then they can get it up and out. So demonstrating for your patient and then having them repeat it back to you is going to be the best way to teach them how to do directed cough or other breathing techniques that we are going to learn. So that is the very basic standard directed cough. For kiddos, I like to say this is what helped Marilyn learn how to get her sputum up and out, was we made a game out of it, and we take the tissue and I tell her, hey, cough into the tissue, and then whatever you get out, you can fold it in half and it makes a butterfly. It sounds disgusting, but it works for kiddos. Same with blowing their nose too. With COPD, you have pursed lip breathing and diaphragmatic breathing, which we are going to go over. Post-op, we have splinting, and then neuromuscular disease, we can use either the mechanical insufflator exflator or a quad cough. And we will go over each of these. So the forced expiratory technique, or the huff cough, consists of 1 or 2 forced expiration with low to middle lung volumes, and the glottis is open. So basically what you do is you have them take a breath in, and instead of breathing out when the glottis naturally closes, you have them force it out, force the gas out with their throat still open. So I like to say like you're fogging up a mirror. So, or if you're like little kids at the window like to fog up the window and then draw in their breath. So you just have them take a big breath in, and then you can hear me wheeze. I'm wheezing. It's allergy season, so I'll probably get some stuff up today. So breathe in and then take that forced breath out. and leaving their throat open. What is happening is the pleural pressure is going to decrease, and it's going to create this back pressure that's going to keep the alveoli open. So thinking of patients that air trap, what kind of patients air trap that you know?
COPD.
COPD, asthma, good. And then CF, they can start air trapping. And this huff cough is going to help pull the mucus off of the airways, which is why it's good for CF, and start moving them. So if we keep all these alveoli open, we are giving the mucus a chance to move from the little alveoli to the larger airways to be coughed out. So this is a good modification for our COPDers, asthma patients, and CFers. Let me make sure I got all my notes. Studies show that it's favorable if the patient is sitting upright, and the more that they practice this technique, the better they're going to get at it. So if you have a patient that you're working with, maybe they're in the hospital for a COPD exacerbation. So every time that you go and give them a breathing treatment and you practice the huff cough with them, this is something that you can tell them as they get close to discharge that they can practice at home to help prevent and decrease the amount of exacerbations and infections that they get. So with increased sputum production, we want the sputum to get up and out. So the huff cough will keep the airways open, like I said, and it will move that mucus to the larger airways so we can get it out. So this is a great technique to be combined with postural drainage and CPT or the PEP device or the vest. So most useful in patients with COPD, CF, or bronchiectasis. So let's see if it will play for you guys.
These exercises help prevent you developing a chest infection or blood clots in your legs after surgery. These problems are more likely when you are not moving around as you would normally. You can do these breathing exercises while sitting up in a chair or bed, or whilst lying down. Relax your shoulders and upper chest. Take a slow, deep, comfortable breath in and hold for a couple of seconds. Then slowly breathe out. Repeat this 3 times. You can start these breathing exercises as soon as you come round from your anaesthetic. You should try to do them every hour when awake until you are fully mobile. If you need to cough, support your wound with your arms, a pillow, or a rolled up towel. If you are struggling to clear any phlegm, try a huff. This is where you breathe out in a short, sharp manner, as if you were trying to steam up a mirror. You should move about as soon as possible after your operation, but while you are not as mobile, try to keep your legs moving to encourage better circulation. You can do these exercises in a bed or in a chair. 1 foot at a time, point your toes away from you, then pull your toes towards your chin. Try to do 10 of these on both feet at least 2 or 3 times an hour. The next exercise is circling your ankles. 1 at a time, circle your ankles clockwise and then anti-clockwise. Repeat this 10 times with each ankle, 2 or 3 times an hour.
So how many different breathing techniques did we see there? So we saw the huff cough.
Huff. Yeah. 3.
We saw
3 of them.
splinting. So we're going to go over splinting. And then we saw just the basic deep breathing, directed breathing. And so that is all something that you can help with every treatment that you do with your post-op patients. Oh, hold on. Sorry. So when, excuse me. So when we're in there with our patient and we're talking to them, we can also encourage early mobility, because what happens to the lungs with someone who is laying in a hospital bed and not moving around? What's going to happen?
Atrophy.
Atrophy. Yep, atrophy. They mentioned blood clots. Secretions are going to take hold because of gravity and sit in one area of the lungs. So we're going to worry about atelectasis and pneumonia. So encouraging early mobility. You're your best patient's advocate, and nursing is doing that as well. But we can help our nurses out by encouraging that, having them move even from the bed to the chair for breathing treatment and back, if they're able to get out of bed. With splinting, you saw at the incision site, you can roll up a towel, or you could use a pillow. Your patients, you're going to find, don't want to cough because it hurts after surgery, right? So it's really educating, rather than just saying, hey, you have to cough, I need you to cough, I need you to get this stuff out, but explaining to them why it's important too, and being a big cheerleader. So even if it's like the littlest teeny tiny cough, tell them what a great job they're doing. Encourage them, hey, let's do 3 big coughs. And then you count down after they're done and say, all right, well, we can take a break for a minute, 2 more left, and then I can leave you alone for a while. So it's communicating with them, being a cheerleader, supporting them. And then when you come back to see them next time, sometimes you'll have patients say, look, I've been practicing, I've been working on my huff cough, or I've been working on my incentive spirometer, which we'll talk about in a few days. And that's really going to make the biggest difference to them, rather than just going in saying, here's your medication, now cough, okay, I'm leaving. I mean, it can be time consuming, but you'll get to a point where you know the routine and how to talk to certain patients, and still be efficient with your time. Okay, so for the other videos, I have posted them in today's resource folder, so you can go back and watch those. There we go. Okay, so excuse me. So our manual assisted cough is also known as a quad cough. This is what we're going to use on our neuromuscular patients. There's 3 options. So we can go in and suction their secretions out for them. But every time we suction, like we'll talk about on Friday, we risk doing further airway damage. It's very uncomfortable and very invasive. So if we can avoid it, we want to avoid deep suctioning. We have the manual assisted cough or the quad cough. And there's a video that you will see in this PowerPoint that shows you how to do it. So it's us pushing up on the diaphragm. So you push the diaphragm down and up to mimic how the diaphragm naturally works when we cough. So we're creating that force that's going to help move those secretions. Or we can use a device called the mechanical insufflator exflator, and that is going to add a positive pressure on inspiration. So it's going to inflate their lungs. And then on expiration, it's going to generate a negative pressure. So it's mimicking a strong breath and cough for the patient because their muscles are not strong enough to do it themselves. So with the manual assisted, the quad cough, RT applies external pressure, as I mentioned. So the patient will take a breath in through their nose as deep as they can. And then we are going to generate that expiratory force to push the air out and help move those secretions. If you work at Craig Hospital, you'll get very good at this. And some patients, it's going to be their preference, whether they prefer the insufflator exflator or if they prefer to be quad coughed. Okay, so know these three options for neuromuscular patients. So patients with neuromuscular disease, it could be a patient with cerebral palsy, it could be a patient with ALS, it could be someone who is a quadriplegic or a paraplegic. All of those patients fall in this category. So on these types of, with this type of cough with manually assisted, so you can see where he's going to push up on the diaphragm to generate that expiratory force. Should we do this on pregnant patients? No. Should we do it on patients with flail chest? No. Should we do it on unconscious patients? No. So if they're on the ventilator, they're considered unconscious. They're sedated. So no on mechanical ventilation. So that's when we would apply suction. And you could also do insufflator, exflator while they're on mechanical ventilation. When we get in the lab, I will show you how to do it on some of our mannequins, and you guys could practice on each other as well. But it's hard to practice on somebody who has a strong diaphragm because you're not going to get quite the same feeling. Okay, another breathing technique that we use is active cycle breathing. So this is taking different types of directed breathing and coughs and putting them into one. So first you start with normal tidal volume breathing, in through your nose, out through your mouth, and you do that 2 or 3 times. And then you do 3 to 4 thoracic expansion exercises. So basically you tell them to take 3 or 4 big deep breaths, as big as they can. And you're going to watch them, their chest is going to pop up and they're going to expand their lungs as full as they can. And then they go back to normal tidal volume breathing and then alternate back to thoracic expansion exercises, back to relaxed breathing, and then they do 2 huff coughs. So at that video at the very beginning, she was doing active cycle breathing. So normal. And then big deep breaths. And then at the very end, do 2 huff coughs. And that will help open the airways enough to move the secretions to the larger airways. And this video is on Blackboard. And our last one is autogenic drainage. So it's using the diaphragmatic breathing techniques. So really focusing on belly breathing is the easiest way to describe it. And making your belly on inspiration stick out, and then on expiration, bringing your belly back in. So learning to control those diaphragmatic muscles to create larger breaths. But there's 3 phases with autogenic drainage. First, you're going to start off with, I find it easier to talk with the picture. So first, you're going to take a big deep breath in so you can pop all those airways open. And then you take small, shallow breaths. So and then phase 2, you go a little bigger than normal. And then in phase 3, you're taking big, deep breaths in to fill your lungs all the way up. So and you want to get through all of these phases without coughing. So back here it states that coughing should be suppressed until all 3 phases are complete. I just got lightheaded doing that. Some patients will get lightheaded, especially if they've been sitting for a very long time. Your chronic patients, your CFers, your chronic bronchitis patients who are used to doing this, and this is part of their airway clearance routine, will start to feel where they have secretions building up at, whether it's a wheeze, or when they cough, they can feel it on one side over the other. And they know that this is going to clear out the bottoms of their lungs. Phase 2 is going to start clearing secretions from the middle of their lungs. And phase 3 is going to clear from the upper airways, the top of their lungs. So small breaths, and they continually get bigger. And then at the end, they will cough a bunch of stuff out.
Sorry to drag it back, but the thoracic expansion exercises, is that just making sure that you're
Big, deep breath.
big, deep breath? Yeah.
So you can tell your patients to put one hand on their chest and one hand on their belly. And as they breathe in, they want to feel their hand on their chest go up and their hand on their belly go out. And it's also a good tool for you as well, because you can watch them and watch their hands move, so you know that their lungs are getting full. Good question. So each patient population is going to have different modifications. So these are the two big ones for COPD. So diaphragmatic breathing is where it's talking about putting your hand on your belly and really using those abdominal muscles when they're on inspiration and breathing in, so that they can use the accessory muscles to help their diaphragm pull down and open up their lungs. And then on expiration, we want them to focus on flattening those muscles to help their diaphragm push all of the air that it can up and out to help with air trapping. So if you have a patient in the hospital who says, I just feel short of breath all the time and that I can't get my breath all the way out, or walking to the mailbox makes me feel short of breath and I can't catch my breath, teaching them how to diaphragmatic breathe and really using those abdominal muscles. They're really focusing on their breathing. So it's going to help with the anxiety, which may also attribute to their shortness of breath, as well as getting that air in. And then we purse pursed-lipped breathing, which can be combined with diaphragmatic breathing. So the patient will take a big breath in through their nose and then out through their mouth, but pursed lips, like they're blowing somebody a kiss or they're blowing out birthday candles. So they just breathe in. And they're slowly going to exhale. That's going to increase their I to E ratio, which will also help with that shortness of breath and that air trapping. So narrowing the mouth with the pursed lips is going to create back pressure, create a more laminar flow on exhalation, and prevent that air trapping. And when we are in the lab, we're going to work with each other, practicing, instructing your partner how to do this, and then you'll be the patient as well. Okay, so for our neuromuscular patients, we have mechanical insufflation, exsufflation. So it delivers that positive pressure, so know how much pressure it's delivering. For 30 to 50 centimeters of water pressure over 1 to 3 seconds. And then it'll abruptly reverse and apply a negative pressure. So it's pushing gas in and then sucking it out. So it's going to mimic a normal breath and open those airways, giving the mucus an opportunity to get to those larger airways. A lot of times you'll want to have a yank hour, which we'll talk about during suction, which is basically a piece of plastic tubing. It's rigid, so it's hard. And when you'll be able to hear the secretions in the back of their throat, or they get into their mouth and you can just suck them out of their mouth. You can use these with a mask. You just have to make sure you have a tight seal. They're like an ambu bag mask. So like we practice with CPR, make sure you have that tight seal, or we can put them directly on artificial airways. So on trachs or endotracheal tubes. Some of the newer devices actually have oscillation on them. So we're delivering airway clearance therapy and coughing for them at the same time. It's pretty cool. So treatment sessions usually last for 5 cycles. Typically, it's also, again, your chronic patients, it's going to be driven by what they prefer or what they need. You can give them breaths, normal spontaneous breaths in between. If they're struggling, if this is something new for someone, it's hard for them to get used to, especially it feels on expiration, it feels like their breath is being taken away. So this is just something that you might have to take time with your patients.
How many is this prescribed like a once a day thing or just as needed a couple times a day?
Both. If you have someone who maybe has copious amounts of secretions, so the doctor might order that you check on them QID, so every 4 hours during the daytime, to make sure. And patients can refuse it. They can say, "Hey, I don't feel like I need it right now," and then you listen to them, and their lungs sound good, their breath sounds are clear, and then sometimes you'll walk into a patient's room and you can just hear the secretions. And you know, okay, well, let's do your albuterol and then let's get you on the MIE. Good question. And then you'll have patients who want you to keep doing it and doing it and doing it because it feels good, because they just feel like they're drowning in secretions. And you can do this. I remember the first time I used one as a new grad, I had to take a patient off a vent and I was doing this and I was super nervous, but once you do it the first time, you'll get used to it.
So there's no like ceiling, as long as it's giving them relief, giving them that sectioning, it's okay to keep doing the insufflation and expiration. Okay.
Mm-hmm. And if what I do is do the 5 cycles, let them do some normal spontaneous breathing, and then listen to them again. If you still hear the crackles, you hear a lot of mucus, or they keep clearing their throat because they feel like they have something back there, then you could do another 5 cycles. So this is what an insufflator exfoliator looks like. So you can see the dial up here. You have positive pressure is the teal and negative pressure is the orange. So the little button, you go this way for inhalation. So you'll look at the pressure that you're delivering to the patient. You don't want to give them too much pressure on inspiration because we don't want to cause pneumothorax or airway damage. We don't want to pop a lung. Oh, I lost my cursor. There it is. And then negative pressure. So you flip it on inhalation and then you toggle it over to exhalation, and you can see the negative pressure here. You want to keep it between 20 or 30. Too much, you can cause atelectasis or airway damage. It even has settings, so you can put the mask on or put it onto the trach, and it will automatically go back and forth in between inhalation and exhalation based on time. This is a newer machine. This video is on Blackboard. And you can see it has a bacterial filter here, and then one at the machine as well. And you can put it directly on the trach. So now we're going to talk about positive pressure airway, positive airway pressure adjuncts. And we use these to mobilize secretions as well as treating atelectasis. some are going to be better for secretions and some are going to be better to treat atelectasis than others. And we can use this with other airway clearance therapy. So directed breathing, directed cough, postural drainage, CPT, chest wall oscillation. So contraindications, we have hemodynamic instability. So if somebody has what we call a soft blood pressure, so it's on the low side of normal, or it's just below normal, and their cardiac patient maybe, we don't want to tank their blood pressure. So think about where the heart sits in between the lungs, and we also have the vena cava. If we're adding positive pressure constantly, we worry about the squishy squish, is what I call it. We don't want to squish on the heart and the vena cava because then we're reducing blood flow back to the heart and then blood flow to the tissues.
That's the professional term, squishy
Yep,
squish.
Squishy squish. That's how my instructor taught me, and I was like, that's the best way to remember it. This is an absolute contraindication. So if they have an ICP, intracranial pressure above 20 millimeters of mercury, you don't want to use this because we don't want to do further damage to the brain. Hemodynamic instability is on there twice. Active hemoptysis. So if they're coughing up frank red blood, we need to take care of that first before we worry about opening those airways. An untreated pneumo, if we add positive pressure to the lungs with a pneumothorax, what's going to happen to that pneumothorax? Yep, it's going to get bigger. It's going to expand. We're going to add more air into the pleural space. If they've had recent facial, oral, or skull trauma, that's going to be a relative contraindication. So we can find the proper adjunct that works for that patient. It's going to depend on how far out of surgery they are and what their comfort level is. Epitaxis, what's that? What is that? Do you guys know? That would be a bloody nose. So that's the medical term for bloody nose. So epitaxis. So if they have a bloody nose, we want to have it stopped first, and then we can come back and help them out. If they have esophageal surgery, we don't want to cause any further damage to the esophagus or remove any stitches. And then nausea. So if someone's really focusing on their breathing and they may have a problem breathing, maybe they've aspirated in the past, we don't want to fill their belly up with air and cause them to be sick. So that would be something that we would just chart. Patient is nauseous, but is stable. We'll come back and check on them later.
So that esophageal suture surgery, is that past history of a surgery, or is that one that is just done
When it's
on the
just done,
patient?
so
Okay.
acute. Hazards that we can cause is barotrauma. So we're making them take bigger, deeper breaths. We're adding positive pressure, trying to open those lungs up. So we are worried about adding trauma to the lungs. Increased ICP. So if they're really focusing on it hard and we're adding that pressure, we risk that. Air swallowing, vomiting, aspiration. So if you notice someone's having a really hard time with it and they say that they don't feel good or they start burping, it's a big sign. Then you can just say, hey, let's take a break. We'll come back later and take it from there. Claustrophobia, so that'll be if you use a device with a mask, some patients may become claustrophobic. And then increased work of breathing. They overworked themselves or they haven't done breathing exercises before. They've been tired and fatigued in the hospital bed. They may have an increased work of breathing, or they get a bunch of secretions up and they start coughing. That is why it's important to pre-treat with albuterol if they have it. So the first one we're going to talk about is positive expiratory pressure. or PEP devices. And then there's also vibratory PEP. So with the PEP devices, the patient actively exhales against a flow resistance. So in the device, I have one here. In the device, there is a flow resistor. So it's going to, on the exhalation, it's going to make it harder to breathe against it. And in turn, that back pressure is going to pop the alveoli open. And these back pressures are 10 to 20 centimeters of water pressure. So this would be a PEP device. And then you have vibratory PEP. So it includes those creating the back pressures with flow resistance, but it also has a mechanism inside of it that fluctuates back and forth to make a difference in that pressure, which creates oscillations inside the lungs. So regular PEP therapy is creating a back pressure. Vibratory PEP has a back pressure along with oscillations in the lungs. Oh, here. So since we're on this slide, I have an aerobica. And this little guy, I love it because you can take it apart and clean it. But on the inside, I'm a very visual person, so it's easier for me to see this. So this is the PEP device, and I just cleaned it. So you see this piece here that goes back and forth? That's what's going to create the oscillations inside the lungs. So when I blow on it and I blow into it, the air is guided through that piece that creates the vibrations. I will demonstrate it in a minute. You might also hear it called a flutter device. So when you have a patient who's doing PEP, and most of the hospitals out there have PAP devices, which we will go over, an easy PAP. So PAP is positive airway pressure. So a PAP device is that fixed back pressure. It's one continuous pressure. And then the Vibra PEP flutters. So a lot of hospitals will have the easy PAP and then a flutter device as well. PAP devices are going to be better for atelectasis, and the vibratory PEP devices or flutter devices are going to be better for secretions. The vibratory PEP devices still work for atelectasis, but if you're only focused on atelectasis, the patient doesn't have a lot of secretions, a PAP device would be a better choice. So patients with CF and COPD love these devices because they have copious amounts of secretions or bronchiectasis. I love them because you can use them in line with nebulizers. So if you have a doctor who orders PEP therapy and they're on albuterol or they're on hypertonic saline, then you can tee them up together. And it's the same amount of time as a nebulizer. So you're only taking the 5 to 10 minutes with a neb instead of doing the nebulizer and then the PEP device, and your time is longer with the patient. Use it 2 to 4 times a day. So you'll have these patients who are familiar. They tell you they use their vibratory PEP at home all the time and they just absolutely love it. And then if you have a patient who comes in who's never heard of it, a lot of hospitals have respiratory protocols. So with the respiratory protocols, you can give them a vibratory PEP and put it as part of their treatment while they're in the hospital, teach them how to use it, and then send them home with it, or get them a new one to go home with. And a lot of your older COPD patients swear by it. If they have just a PEP device, most of the time you shouldn't wake them up during the night to do a treatment. So this is something you would do QID or TID. And then you'll have the patients who can demonstrate how to use it. And you may not have to necessarily go see them. You can write in the chart, instructed patient how to use PEP device. Patient demonstrated that they can use it on their own, told them to call with any questions or concerns. And then you don't have to go see them. But then you'll have those patients that you're like, well, come on, it's time to do your acapella or your VibraPEP, and then encourage them to cough after they're done using it. So this is something that you're not going to use with children less than 3 years old. They can't generate that expiratory flow. And they can't, so when we use this, I'll show you here in a minute, we don't want to puff our cheeks out like chipmunks. So when you blow into it, you want to blow like you're blowing out birthday candles. So you can feel the oscillation in your chest. If you get that air trapped in your cheeks, that oscillation isn't going to go into your lungs. For post-op atelectasis, we want to instruct them to take big, deep breaths and do the IS. And then patients who can't take a deep breath aren't going to benefit from this because the oscillations and the vibrations aren't going to get down to the lower lungs. So here are some devices. So I have the Aerobica, which I will show you. This one's called the VibraPEP. This one is really easy to clean as well. So this tube goes inside this little piece here, and then you can attach it and tee it up to a nebulizer or just a mouthpiece. And this little plastic piece here, as you blow into it, it expands with the air and then collapses. So because it's so tight, when that air travels through, it creates that oscillation. These are the acapellas. It is a flutter device as well. It has a very similar piece like the Aerobica that fluctuates back and forth that creates the oscillations. And this is the basic flutter valve, the original. This one, because of the shape of the mouthpiece, cannot be teed into a nebulizer. I haven't seen it in a hospital in this area, but it doesn't mean you won't see it at some point. And as a patient exhales into it, this little ball moves around in this cup and covers the opening and obstructs it, which creates cutting off the air and the oscillations. Okay, so the EasyPAP here, you can see it has oxygen tubing. So it's pneumatically powered. So with EasyPAP, you have to have it either attached to oxygen or air. And that PSI from the wall is going to create the pressure here into the device. And you can set it from a pressure of 5 centimeters of water pressure up to 20. And it's a continuous flow. So it's always going. And it's going to provide a little bit of positive airway pressure on inspiration and splint those airways open. But on expiration, it's forcing the patient to breathe harder against that pressure. And that's going to help with atelectasis. So EasyPAP or any of the PEP devices are going to be good for atelectasis, where the vibratory, all of these guys, the vibratory PEPs are going to be good for secretions. So here is acapella, atelectasis. It can treat, but it's not going to be the best for it. COPD, chronic bronchitis, emphysema, bronchiectasis, cystic fibrosis, asthma, those are all going to benefit from oscillation. So with this one, you have an adjustment here. I don't know if you can see it on my camera. So you can adjust the resistance and the oscillation to make it harder to breathe against or easier. So when I set this up for a patient, I always start out in the middle and see how they do. If they say it's really hard, then you can go down on the setting. If you hear them breathe really fast, so I'll show you how to do it. They need a tight seal around the mouth, and then they blow out like they're blowing out birthday candles. I don't know if you guys could hear it. Did you hear kind of the vibration?
No.
So keep the cheeks in. Now, if they get it and they go, it's obviously too easy. So then you'd want to turn it up a little bit. As patients start to feel better, the infection starts to go away because their antibiotics are working, or they're doing a better job coughing out their secretions, you can increase the intensity of those vibrations. So this is Marilyn at our old house. So you can see we have the breath enhanced neb here. She's on her vest, and then she's using the Vibra PEP as well, which she has, her cheeks are out. So even though with kiddos, if they use them in the cheeks and they're chronic patients, it's good to start having them learn how to do it now. Now she'll sit, if she feels like she's using her cheeks too much, you'll see kids sit like this and squish their cheeks closed, because then it's going to go into their lungs. So high frequency compression and oscillation, we can do it externally with a vest. So this is a vest, this is an old vest. So she's pretty young here. She's about 5. So the vest inflates and deflates, creating pressure, and it pulses against the chest wall. So it pretty much, it shakes them and it moves them around to help that airway get off the chest wall. We have the Hillrom, and that is called the vest. So this one is Hillrom, and it's the vest. You guys will get a chance to put on the Encourage vest when we go into the lab. And it has 2 hoses. And then those hoses send the air in here to deflate and inflate the vest to create those pulses. Electromed has the Smart Vest. Respirotech has a vest, which you can try. And then the Aflo vest, which is, has anybody seen 5 Feet Apart? So
Looks too sad. Can't do it.
It's a really good movie. I did cry. Marilyn loves it because it made her feel like she's not alone with CF, which I thought was great.
Because it's about 2 people with CF, right?
Mm-hmm. Yeah. She has the main character has an Aflo vest, and it's really cool because Marilyn got one. I should have brought it down here. I'll upload a video that Marilyn did explaining her vest onto Blackboard because she likes to educate students. So I have a bunch of videos I'll spam you with if you would like. But she can go outside and sit outside with us while she's doing her vest, when she's done with her nebulizer. So it gives us sort of freedom. It's really cool. The Monarch by Hillrom is also hoseless, but it is only for patients 12 and up, and patients who have pacemakers can't use it. Whereas with the Aflo vest, there's no age limit. It even comes in little teeny tiny baby sizes, and there's no contraindications. This is an Aflo vest. So this is Morgan. He does all kinds of CF videos on YouTube and Instagram, reviewing the first Aflo vest. So he's a CFer. You can see he's got his neb here and an aerobica here. I'll let you watch that video when you guys are ready to. So another way that we can get compressions and oscillations into the lungs is internally. So we have IPV, or the Metaneb. IPV is like the dinosaur of internal oscillations, and more hospitals are switching to Metaneb. But if you go to Children's, you will still see the IPV and have to set it up. Both of these are pneumatic devices, so you have to have oxygen to set them up with. and it delivers a mini burst of gas. So when we go into the lab and we can play with this, vests make a noise where it's like, and the gas does, the pneumatic devices do the same thing. It uses the gas from the wall, and you can either have a CPAP setting, which is continuous positive airway pressure. So it's a straight continuous flow, or the mini burst. You can set it to the mini burst setting. And then so it oscillates that gas. So it has a and you can change the frequency and the depth of these oscillations. So it's like breathing on a neb, and most of the time they're teed up with nebs, and you can put them on mechanical ventilators as well. So they're breathing through this, and if they're not on a vent and they're using a mouthpiece, you need to instruct them to breathe in and out through their mouth. And it can deliver aerosolized medications. So we'll get to play with these. They're really cool. And Hillrom just came out with, I can't remember the name of it, but it's a neb for home use. So it's super cool. Jay, do you know what it's called? I saw you shaking your head.
I don't remember, but I know Derek was talking about it the other day too.
Super excited.
Yeah.
Marilyn's RT and I were totally geeking out about it.
The metanubs are really cool, so I bet it'll be awesome.
IPVs are more difficult to set up, and they're not as comfortable for the patients. So when Marilyn was inpatient in February, her pulmonologist was talking and asked if we should try the IPV because she had pneumonia, and her RT and I were standing in there. We're like, no, she's a little young and I don't want to scare her from it because Children's doesn't have metanebs yet. They're working on getting them, but COVID, they can't have any vendors come out yet. So they don't have metaneb yet. Does the university still have the IPV?
Are those like the big ones that you plug in and it's like a massager almost?
That would be a
Just pressures,
percussor.
huh?
That'd be a percussor.
I don't know.
I bet they got
Not
rid
that
of
I
their.
think of. Yeah, we have quite a few
Okay.
metanebs.
Metanebs are great for burn patients who are on the ventilator because it helps get that dead, nasty tissue out of the lungs too. So you will be using airway clearance therapy for all kinds of patients, whether they're on the floor, in step down, or in the ICU. This is what the IPV looks like. So you have a bunch of different lines here. And then you can change the pressure based on patient comfort. And you can see here, this is telling you what pressure is being delivered to the patient. And then with the metaneb, it's super cool. So you can have continuous positive expiratory pressure. So this is the pressure that is constantly being delivered to the patient. Or you can change it to oscillation. So a lot of times you'll do 2 minutes of just expiratory pressure. So the patient has to breathe against this pressure. And then you do 2 minutes of oscillation. And that's helping draw the mucus out of the alveoli into the larger airways, and then switch it back over to continuous pressure and then back to oscillations. If the patient needs a break, there's a switch. So this little guy here, it's just letting the patient spontaneously breathe without any other pressure, but the medication is still going. And then oscillations, you can pick between two depths. So if you want more oscillation or less oscillation. And then flow, so how much flow they have to breathe against. And you can see here, so if your patient is having a really easy time breathing against the flow you set, you can increase it to make it harder for them and make their lungs work harder, and it's going to open up the lungs. And then this is just a picture of it being teed into a ventilator circuit. So it can create those oscillations through the inspiratory limb. Something that often gets forgotten about is exercise and physical activity. Exercise and physical activity cause our body to naturally increase tidal volume, heart rate, cardiac output. It's going to cause improved physical conditioning. So I know I talk a lot about CF, but it's what I know the best. So with CF, Maryland's encouraged, all CFers are encouraged to have an exercise routine, anything that will increase this tidal volume and ventilation. Physical therapy is part of the team at Children's. So they work on balance. They take pictures of Maryland's posture, because posture is going to tell us, are they having a harder time breathing? Are those accessory muscles working harder? How's their lung volumes? So like even think about running. Every time your feet hit the ground, you're kind of jarring your lungs. You're going to help secretions. So physical activity. So let's do a couple questions. So a 19-year-old patient with CF is preparing to move away for college. At home, the patient has been receiving postural drainage and percussion at least twice per day. Which of the following would be suitable for when the patient's away from home? So we have portable small volume nebs, instruct her roommate on percussion therapy. So that's manual CPT, PEP therapy, or hire a home health practitioner to perform percussion daily. Which would be the most feasible solution?
PEP therapy?
Yeah, I'd say PEP.
PEP therapy. So that's the great thing about PEP therapy that I want to talk about is it's super small. They're small and we can put them in line with nebs. So if they're doing proper, she's 19, he's 19, I don't think I was specific here. So the patient's 19, they can take instructions well and be active in their care. So PEP therapy by itself without a vest would be fine for this patient. If your families are traveling and the kiddos can do adequate treatments with PEP therapy, they don't have to travel with their vest. And also 19, you don't want to be different, right? There's a big mental stigma that comes with CF. They want to be as quote unquote normal as possible. So PEP therapy would be the best device here. So while training a patient to perform PEP therapy, the RT notices sudden development of bronchi, followed by an episode of vigorous coughing. The therapist should continue therapy, halt the therapy, and consider to another clearance technique, lay the patient in the supine position for several minutes, or re-instruct the patient on better technique.
Stop and try another device or another technique.
What is bronchi telling us in coughing? What's our goal with PEP therapy?
Mobilize secretions.
Yep. So, excuse me. So this is doing what it's supposed to do. So we would continue therapy. So things that we want to look for are a change in breath sound. So if you go to a patient's room, you've looked at their chest x-ray, they have consolidation because of a pneumonia, and that's why you're doing PEP therapy and cough. And you pre-treatment listen to them and they're just very, very diminished. If they develop bronchi or crackles, you can just hear, or improvement in aeration, then you know the therapy is working. We want them to cough stuff up. So now here I would say you could pause for a minute, let them catch their breath, get their sputum out, and then continue therapy. But you wouldn't necessarily need to switch. So you'd want to continue PEP therapy. We've talked about crackles. What else might we see on a chest x-ray? What might be some signs and symptoms of increased secretions?
You've got the infiltrates and the bronchioles.
Yep.
So I
Infiltrate.
don't know, it
broncho
called it
air-
like cuffing or collars, bronchial collaring or something like that.
Bronchograms. Bronchograms could be another
Bronchograms, yeah.
sign. What might happen with their oxygen status if PEP therapy works? If it works, it'll go up. If they've retained secretions, it'll go down. Good. What was my other question? Do you guys have any other questions? I know it's a lot of information really quick. It's hard. I have to give you guys a lot of respect because it's hard to learn all this online and not be able to physically go into the lab right after we do it with lecture. So you guys are doing great. You did great on your aerosol exam.
Woohoo!
Yes, you guys all did good. We'll do more hands-on in the lab. I'm excited to get into the lab. So as you're going through your disease class, and maybe go back into some of the obstructive diseases you've learned and start creating patient charts of your own or scenarios where you create your own plan for your patients. Well, what you're doing, what tests they need with Derek, right? Maybe add, okay, from therapeutics to what can I add to this patient's care plan? Just a thought. What helps you guys study? What can I give to you to help you study, to help pull this all together?
I always like Quizlets. I don't know.
Quizlets?
Whenever Gina would post Quizlets, they were helpful.
Okay. We can do that.
I kind of like fill in the note, fill in the blank notes, stuff like that.
Like Derek does? Okay.
Yeah.
Do that.
I think Gina did them too. She like had separate pages, and for the lecture, for the PowerPoint, like you could print it out and fill it in as you go.
Oh, I'll have to ask Gina about those so I can see what she's doing. Sounds great. Yeah, start creating care plans, or something else that has worked for past classes is you guys can create your own scenarios and then send them to each other and fill them out and see how you did. Because you might catch something that somebody else didn't catch. Or they might ask a question, well, what was this, what were their eosinophil bands like on this patient? So baby eosinophils, which are baby white blood cells, means that there's an infection, right? So trying to put all of these pieces together can be difficult, but it sounds like you guys have good open communication with each other. So keep studying together. I think that will help you guys the most in this class.
Yeah, and I'm always a proponent for, especially for like the charting. I cannot never like until we start writing charts. It's seeing a couple examples of a filled out chart for some of these PEP patients or an order, what an order would look like for somebody getting placed on these therapies might help me, just so I can I'm not going to just write it all down and copy it, but to know what it looks like.
I'm writing myself a note to send that out too. And I can even we can go over that a little bit on Friday as well. I'll come up with something so you can start to see what a patient load might look like or how you would develop your own care plan.
Yeah, and even seeing a pre-therapy patient chart and then a post report on that same patient, seeing if there was any therapeutic index or not index in effect. Improvement. Some I word, I don't know, but just seeing what the difference in charting would be, seeing your patient a couple different times, I think would help me.
Yeah, sounds good. I can create that for you guys because every class has different study styles and tips. So I can do that, and we can go over that on Friday too when we talk about trachs and sectioning. Awesome. And I will put up those videos of Marilyn so you can see a real patient. Sometimes I like the videos where they teach you how to do it, but they're actors. So
Yeah,
like watching me
we
do
watched
it.
like one gal on Instagram who had cystic fibrosis and did her treatment and kind of, but it was more just like a vacation video plus a little bit of CF knowledge.
Yeah.
So-
And I will find some other CFers, I think, are because CF is such a wide range of patients. You have, you know, kiddos to my age, and then now we're starting to have older CF patients, which is nice. And they can send videos too. So the Fry Life is a great example of CF treatments. So I will post that too. All right. I will let you guys go and we'll see you on Friday.
And we just have the clearance questions and the MRE for
Yep.
today.
That's it.
Cool.
All
Hey,
right.
Stacy, I have a quick question.
Yeah.
So the professional hours, are those due by the 30th or just before we go out in July?
They're due by the end of your rotation.
Oh, okay.
So
Got you.
professional hours will be due, these first ones are due the end of floor rotation, and the next ones are due at the end of the ICU rotation, and then your last ones are due the end of the NICU rotation.
Awesome. Thank
question.
you so much.
You're welcome.
There wasn't a PowerPoint up for trach yet. I don't know if you got my email. I didn't see a PowerPoint up yet. I was trying to get everything printed out.
Oh, I will go double check that now.
Or I don't see it and I'm just being blonde.
It didn't attach. It might have not have attached.
Okie
I've been
dokie.
having
Thank you.
issues. You're welcome.
Yeah, no problem.
All right. Bye, guys.
Stacy, I was wondering if there's